Next, I like to invite Dr. Samyukta. She is assistant professor in Government Medical College, Thrissur, and our in the hospital alumnus. She will be speaking on varied presentations and examination sequence.
Good afternoon, everyone. Sir Arthur Jampolsky has rightly stated that the diagnosis of DRS is established by the examiner being aware of and recognizing the various patterns. So we move ahead with our topic, the varied presentations and clinical examination sequence. So these are the reasons why DRS patients seek an ophthalmologist's attention. The possible presentations are limitation of ocular movements, noticeable ocular deviation, altered head posture, or cosmetically unacceptable vertical movements. So, apart from the routine points which you will attend to in a history-taking protocol of squint, give more stress to the onset of deviation. Most of the times this is a congenital anomaly, but which presents very late to the clinician. And give due stress to the presence or absence of diplopia and its onset, and give importance to the presence and onset of anomalous head posture, probe whether it is present at all times of the day, whether it is present for distance or near, and look into associated hearing deficits and neurological issues as well. Now, these are the different presentations. We might not have seen all these types in a routine clinical practice. It can be a unilateral DRS or a bilateral DRS. The classic is the ESO-DRS. ESO-DRS with anomalous and normal LR activity. ESO-DRS with overshoots in opposite gaze, relatively immobile globe, simultaneous abduction with no retraction, fixation with the DRS eye with overshoots in the opposite eye, Y pattern, lambda pattern, subnormal LR without anomalous LR. Now, bilateral patterns are seen in 15% to 20% of DRS cases. They can have fusion, may not have fusion also. Rare varieties include vertical DRS and synergistic divergence as well. Now, this is a case of synergistic divergence, where you see large exotropia with gross adduction deficit, and as soon as the patient is attempting adduction, there is a simultaneous abduction. And this is vertical retraction syndrome. Here, there is a horizontal DRS with a globe retraction in vertical gaze positions. And there may be associated limitation of vertical eye movements. Here, this patient has a limitation in infraduction. And this is bilateral ESO-DRS without fusion. So, as you proceed with your clinical examination, inspect for these different things. Divya has already mentioned the coexisting anomalies, and give due importance to multidisciplinary referrals whenever you suspect a systemic association. So, you proceed with your visual acuity estimation with age-appropriate methods of vision assessment. Hypermetropia, hypermetropic astigmatism constitutes the most common refractive anomaly. Accommodative element has to be ruled out by a cycloplegic refraction. You can reserve it to the end of your examination. Amblyopia, the major causes are anisometropic amblyopia and ametropic amblyopia. Strabismic amblyopia is seen in 25% of bilateral DRS. So, you're starting your motor examination aspect. Measure your head posture in degrees, document it well. It is important preoperatively to assess your results postoperatively. So we know this is to maintain binocular single vision and to make up for the duction deficit. Fatima madam has demonstrated her own innovative mechanism, cost-effective mechanism to measure the head postures. Document the ocular posture, presence of nystagmus, ptosis, pseudotosis, facial asymmetry, if any. Now, ocular rotations, this is the cornerstone in diagnosing and differentiating DRS from similar clinical entities. Do it in neutral head posture, and a thoroughly done ocular motility examination will help to pick associated motility disorders, incomitants, alphabetic patterns, etc. Versions to be checked first, followed by ductions, all the deficits to be noted here. And you can on the spot take an iron gaze image to have a reference to later on. Now, all these anomalous vertical movements, overshoots, globe retraction, narrowing and widening of palpebral fissure, all these things become evident at the end of your ocular motility pattern examination. Now, these are the notable features. Abduction deficit, which is disproportionate to the primary position deviation. And the underlying adduction deficit becomes evidenced by remote NPC. Another interesting feature is that an ESO-DRS may have an exotropia in the opposite gaze due to the underlying adduction deficit. So this is your screening Hirschberg test. The deviation can be an ortho-DRS, exo-DRS, or ESO-DRS. Esotropia is the most common primary position deviation. Cover tests follow to be done in habitual head position and also in the forced straight ahead primary position. Abducting saccade of the DRSI will be poor during the cover test. You quantify the deviations by doing prolonged prism alternate cover tests to be done with the prism in front of either eye separately. So this will give you the primary and secondary deviations. Upshoots and downshoots are seen in nearly 43% of cases. So if you do your examination correctly, you will get to know whether it is a mechanical overshoot or an innervational overshoot. So mechanical overshoot occurs abruptly, whereas in innervational, it is a gradual movement. Mechanical overshoot is it is peculiar in that the upshoot and downshoot can occur simultaneously in the same patient, whereas in innervational, either of these would be present. Both cannot simultaneously be seen. Vertical deviation in primary position is not seen if it is of mechanical etiology, whereas in innervational overshoot, there would be a typical large vertical deviation in primary position. So these have already been told about: grading of overshoots, grading of globe retraction. And the patterns, V pattern is the most common type which we see in DRS. In bilateral DRS, they tend to have A pattern more frequently. Now this is an image of a lambda pattern DRS. Sensory examination follows: Wirth 4 dot test, stereopsis test. Now coming to the most important thing when you plan your surgical correction of DRS, do have a very good idea about FDT, active FGT, and force degeneration test. So we know in routine FDT, the patient is instructed to look as far as possible into the field of action of the muscle being tested. The examiner proptoses the globe by using atraumatic forceps and then holds the limbus and sees if the globe can be rotated passively farther than what the patient can do by himself. So that is the routine FDT. Here in DRS, we use FDT to assess the tightness of lateral rectus as well as medial rectus. In DRS, this force duction test in the opposite gaze helps to give an idea about the anomalous innervation as well as mechanical restriction forces. So I'll state an example. Suppose there is an ESO-DRS in the left eye, type 1. FDT on the affected left lateral rectus would be free. FDT negative on attempted abduction. Okay, because there is no LR innervation. On the other hand, when you do this on adduction, this will be paradoxically positive because on adduction, the LR gets the anomalous innervation. Now, this resistance gets relieved when the patient is asked to abduct the eye because the globe is now not getting any innervation in abduction. So relief of restriction is due to absent LR firing in left gaze. Force generation test, here the patient is instructed to look maximally in the field of action of the suspected muscle, and here the surgeon grasps the eye in the opposite limbus, pulls against it to evaluate the muscle force, or more appropriately the encountered resistance. Now this is one specific test which is described specifically for DRS. Romero-Apis force degeneration test. We do not do it in every case. This has to be done whenever you want to differentiate. There is some clarity regarding the differentials is required. So here, the patient is asked to look halfway between the primary position and full adduction. Now the examiner holds the temporal limbus and he further attempts to push the eye more into adduction. Patient is also asked to adduct the eye. At this moment, there is a resistance which is encountered because of the co-contracting lateral rectus muscle. Now from the same position, the patient is asked to abduct the eye. So this is how it goes. So in the first image, you see that the patient is made to fixate between primary position and full adduction. Second step, the examiner is pushing the eye into adduction. And from that adducted position, now the patient is instructed to further abduct the eye. So what is happening here? Initially, there is a resistance in adduction felt because of the co-contracting lateral rectus muscle. In step 3, as the patient attempts the abduction, the previously present resistance now disappears because the LR innervation is nil now. So that is Romero-Apis force degeneration test. So before you take up the patient for a surgery, 5 questions need to be answered. What is the degree and quality of LR co-contraction? So this you will get to know by a thorough observation and grading of the overshoots and globe retraction. Question 2, is there any degree of LR recruitment on abduction? Is there any residual LR activity? Here you go for observation plus active FGT. Now, what is the MR type? What is the contribution given by MR contracture? Go for an FDT. Now, what is the cause for adduction limitation? Is it due to tight LR? FDT tells you the answer. Is it an underacting MR? FGT gives you the answer. And if there is a co-contraction present or not, force degeneration test will help you. And is there any secondary change in vertical muscles? This will be evident if there is a hypertrophy in primary gaze position. Most often it is the superior rectus muscle which will have a secondary change. So diagnostic factors necessary to manage DRS patients include pattern recognition, primary position deviation, presence of fusion, severity of dominant features, presence of any residual LR innervation, secondary muscle changes, and fixation if present or not with the DRSI. Cycloplegic refraction to be reserved to the end of your examination.